The pilot study is part of the wider European project UONCOL, which, as just mentioned by Cinzia in her introduction, aims to develop, validate, and disseminate the UONCOL kit for the assessment of health-related quality of life in persons with current or past cancer experience. The toolkit has been developed through an iterative process of several steps involving multiple stakeholders, including also patients. And we are currently in the second phase, which is the validation of the toolkit through its first large-scale application in a pan-European survey of participants from many European countries. Just a quick sum up of the main features of this toolkit. So it will be used in European cancer programs and policies. It is developed from the patient's perspective according to the co-design approach mentioned by Cinzia. It is available in several European languages of the EU member states and associated countries, and it will be electronically administered. More importantly, it is intended to assess health-related quality of life across the whole cancer care continuum, including people at different stages of their disease trajectory, since it is very difficult to find a comprehensive definition of the target population that takes into account the complexity of these patients, especially those in a disease-free stage. For operational purposes, 3 target groups have been defined. So group A, active treatment, patients in active treatment, so undergoing or being eligible to curative or life-prolonging tumor-directed treatment. Group B, survivors, being at least 1 year of treatment and being disease-free without evidence of active cancer. And group C, people in palliative care, having metastatic or locally advanced disease and receiving tumor-directed treatment with palliative intent, or being not eligible to any tumor-directed treatment. The UONCOL kit has been developed according to these definitions, and of course the validation study will test the toolkit with participants who fall into these 3 definitions. Last important feature is that the UONCOL kit can be administered both in a static and a dynamic mode. The static mode implies the classical testing, so with a fixed set of pre-selected questions presented to every respondent, while the dynamic version is based on the computer adaptive testing, so that questions will be automatically selected based on the respondent's answers during questionnaire completion. So, for example, if a patient, if unable to work a short distance, the patients will not be asked if they can work for a long distance. And so this dynamic version, provides patients with a more tailored questionnaire. So at the end, since we had 3 target groups and 2 administration modes, the toolkit will be composed of 6 different questionnaires, so 1 static and 1 dynamic questionnaire for each target group. So the primary aim of the study, of the pilot study, is to validate the psychometric properties of the toolkit by assessing its validity and reliability. The secondary aims include assessing its acceptability and patient burden by measuring the response rate, the reasons for refusal, and the time taken by the patients to complete the questionnaire. Then the cross-validation of the static and dynamic administration modes, and the exploration of individual factors potentially affecting health-related quality of life and inequalities across European countries. The study is a multi-center observational cross-sectional study. So 45 clinical centers from 25 EU member states and 7 associated countries will be involved in data collection, coordinated by OECI. And it is observational and cross-sectional because, of course, participants will not receive any kind of intervention, neither pharmacological nor non-pharmacological, and patients will only be asked to fill in one or more questionnaires at a single point in time, except of course, for the retest, which will take place at least 1 hour apart. Inclusion criteria for the patients to be eligible for the study include being 18 years old or more, having present or past histologically confirmed diagnosis of solid tumor or hematological malignancy, being one of the 3 defined conditions, so active treatment, survivors, and patients in palliative care, being native tongue or fluent in the language of the questionnaire, and giving written consent to the study, of course. Patients will only be excluded in case of cognitive impairment preventing questionnaire completion. As for the main procedures, we expect a study population of 4,000 patients. So each clinical center, we have 45 clinical centers, each clinical center will recruit 100 patients assigned to the 3 defined patient groups. So 40 patients in active treatment, 30 survivors, and 30 patients in palliative care. And also to get a minimum variability in terms of primary oncological diagnosis, the 100 patients will be recruited according to the stratification you see here. Of course, these are indicative numbers which can deviate a little bit from this table according to the availability of the patients in each clinical center. During the data collection phase, all 100 patients in each clinical center will be asked to complete the static version of the UOncol kit according to the following scheme. So 70% will complete only the static version of the UOncol kit. 100% will complete both the static UOncol kit and an already validated and well-known questionnaire. Actually, it will be a combination of 2 questionnaires, the FACT-G and the 5-level EQ-5D, to test the concurrent validity of the toolkit. 10% will complete both the static and the dynamic versions of the toolkit to cross-validate both administration modes. And the last subsample will perform the test retest by completing the same static version of the questionnaire at least 1 hour apart. Finally, the patient recruitment and data collection will take place in pre-identified outpatient clinics and inpatient wards of each clinical center. And data collection will start in the next weeks and will continue in the months of the second half of 2024 during specific days previously agreed with each clinical center. And patient registration and data collection will be centralized through a dedicated web platform, and questionnaires will be administered through tablet devices through a mobile app. Then, at the end, based on the data analysis and the results we will get from this study, from this validation study, the toolkit will be further refined and finalized. And of course, after this validation stage, different implementation strategies will be put in place to guide and disseminate the use of the tool. So for example, in the framework of the EU Mission on Cancer, to support the core principles of this initiative, which is to improve and preserve quality of life at all stages of the disease, or in coordination with other EU-funded projects and research activities to complement existing health outcome measures, and finally to inform evidence-based policies and other research initiatives addressing cancer inequalities across Europe. Thanks.
Sorry. Thank you very much, Luana. Before giving the floor to Claudio Lombardo, that will explain the special value of this project for OECI, I would like to highlight 3 points very important according to my understanding of the project. Here we are talking about a questionnaire for cancer patients that is not appropriate to be applied in clinical studies, is not appropriate to be used in clinical practice, but it's a survey that should be used for survey in cross-sectional or longitudinal in order to understand the effect impact in terms of quite large sample of cancer population, in order to understand the effect of giving intervention within or without the cancer mission projects. The second point, that this pilot validation study at the very end will produce some data in terms of validity, in terms of reliability, in terms of concurrent validity and capability to interpret the score, but should not be considered the normative data to be used to compare so far in this point of the study subsample or countries. The idea to increment the kind of representative data is objective of the following 2 years with different kind of initiative that we already wrote in the proposal and we have to implement after giving to the European Commission the result of the first 2 years that are the questionnaire in the different formats and the empirical data demonstrating validity, reliability, content, concurrent validity, and interpretability.